We wrap up Disc 1 with a discussion Carl Pepine had with Dr. Bertram Pitt, Emeritus Professor of Medicine at the University of Michigan in Ann Arbor. They discuss aldosterone antagonism revisited, new indications, and new trials.
Bert, could you give our listeners a little bit of insight into how this work started?
Well, first of all, I think most people know that mineral corticoid receptor antagonists, or aldosterone blockers, if you will, have been successful in reducing mortality as well as hospitalizations for heart failure across the spectrum of patients with heart failure and a reduced ejection fraction. We've had the RALS trial, we've had emphasis with post-MI heart failure, and we've had emphasis in patients with systolic heart failure and mild symptoms. So there's pretty convincing evidence and a class 1 indication that on top of our current therapy, which is a beta blocker, an ACE or an ARB, that adding a mineral corticoid receptor antagonist has a tremendous benefit. And then we've just recently had the TopCat trial, which is going to be appearing in the New England Journal on April 10th in heart failure and preserved ejection fraction, where spironolactone was used on top of standard therapy. And the overall endpoint of the trial, which is a combination of cardiovascular death, resuscitated cardiac arrest, and hospitalization for heart failure, didn't reach significance. But the trial is sort of complex, and it was very striking. There were marked geographic differences, and about half the people came from Russia and Georgia, half came from the Americas, Canada, the U.S., and South America. And in Russia and Georgia, for some reason that we still don't understand, the placebo event rate or the control event rate was very, very, very low and not compatible with what we think is heart failure, and in fact is just about the normal population. So we don't quite understand that. And in that group, there was so low an event rate, there was no benefit. But in the Americas, where there's a reasonable risk rate, we saw a significant reduction in the primary endpoint. But of course, that's retrospective and post hoc, so you have to take it with a few grains of salt. Nevertheless, I would say, look, a lot of people are using ACEs and ARBs and beta blockers in diastolic heart failure or HFpEF, and there's not a lot of good evidence there. And here's at least a clue, and I leave it up to you to decide what to do.
Well, thank you for that overview, Bert. Can you give us some insight into the mechanism?
When you and I went to medical school, Carl, which was a while ago, I think we learned that aldosterone was important because it stimulated the mineral corticoid receptor in the epithelial cells of the renal tubule, and that was responsible for sodium retention, potassium loss, and it gave spironolactone, get rid of fluid, and you retain potassium. And since that time, people have discovered there are MR receptors not just in the renal tubule, but in the myocardium, the vascular wall, the brain, the skin and the eye, and the colon. And there's been a tremendous understanding of the mechanisms, and that understanding is still ongoing. We all learned that angiotensin stimulated the release of aldosterone from the adrenal gland, and that is true. On the other hand, we thought that if you blocked the AT1 receptor, you would block aldosterone. That's only in part true, because there's good evidence if you have an angiotensinogen knockout animal, a mouse, and there's no angiotensin around, you can still stimulate aldosterone. Of course, there are alternative methods. And the other thing we've learned is that AT1 stimulates the release of aldosterone, but when you have MR activation, you upregulate the whole RAS system. So you upregulate the AT1 receptor and ACE. So there's a vicious cycle. And the next thing we learned is that you really have to block both angiotensin II and aldosterone to get maximal benefits. If you just do one or the other, you get some benefit, but when you put them both together, and all of our trials have looked at the role of an MR antagonist on top of an ACE or an ARB in standard therapy, and it works, and there's good experimental data for that as well. The other thing that we've learned over the years is that it's not all aldosterone that stimulates the mineral corticoid receptor, because the receptor has tremendous affinity for cortisol. Now, in the kidney, there's an enzyme, 11-beta-HSD2, which converts cortisol to cortisone, which is inactive, but that enzyme is not present or not very well abundant in the myocardium. And as we sit here, cortisol is sitting on our MR receptors, but doesn't activate it unless there's an increase in oxidative stress. And there are a number of things that could increase oxidative stress, and one of them is sodium. So if you have a high sodium diet, as we do in the Western world often, then you have an increase in oxidative stress. And another vicious cycle, that aldosterone increases ENaC, the expression of sodium channels, and so you get all these vicious cycles going on. The other thing that's become apparent in the last few years is that aldosterone and activation of the mineralocortical receptor plays an important role in inflammation. And also, it's been shown that if you stimulate the mineralocortical receptor, you have an increase in reactive oxygen species. And once again, tremendous effects on signaling pathways. And if you give an MR antagonist, you improve mitochondrial oxidation. Perhaps one of the most exciting areas is the realization that the macrophage plays an important role. I think we've heard over the last few years that in hypertension, heart failure, and all of vascular diseases, that inflammation, the activated macrophage, plays an important role. And there have been some very interesting studies where they've taken in animals and they've knocked out the mineralocortical receptor on the macrophage. The macrophages have MR receptors. When you knock out that receptor, you prevent remodeling, or if you prevent activated macrophages from coming into the myocardium, you can prevent remodeling. That's important to us because there's a group at the University of Michigan, which I'm working with, that has shown that with a new polymer, we can link a plerinone to the polymer and a linking molecule and make it only go to activated macrophages. And in our animal models, it's not in man, so it's a long way to go, but in the animal models of heart failure, we seem to do a better job in reversing fibrosis and remodeling and oxidative stress with our sort of site-specific delivery, where we've put it to activated macrophages rather than standard plerinone alone. But there's a long way to go from animals to man. But it's also been shown that there's new signaling. We've known about non-genomic effects, but there's a great understanding of how those occur through caveoli and stimulating sodium channels. So there's a whole new understanding, and also MRs in the vascular wall are turning out to be very, very important in vascular injury. So in the future, by understanding some of these mechanisms, there may be alternative means of blocking the MR, which may be safer and doesn't have hyperkalemia or maybe target specific. So I think we're gone a long way, but I think there's a long way to go and a very exciting path forward.
Bert, most of our listeners are clinical cardiologists. One of the things that I've noticed, even though we have this overwhelming data that you just summarized for us in the major trials, if you look at what guideline recommended medications are missing from most patients, it's the aldosterone antagonist. Any thoughts on that?
That's mainly related to the fear of inducing hyperkalemia, which is real, but in our trials, where trials are not real life, trials are where we carefully select patients, we've not had any major troubles. But in real life, what happens, in fact, there's some very recent studies that despite the guidelines and the class 1 indication, that a lot of people don't measure potassium or renal function before they start, and they certainly don't measure it serially. So if you're going to give a mineralocortical receptor antagonist, especially to people with renal disease, you really have to measure renal function and potassium at baseline and be willing to follow it serially so you can adjust the dose. But if you don't do that, you certainly can get into trouble, and you probably shouldn't go there. But if you're willing to do that, there's obviously tremendous benefit. So I think that's part of the real disconnect between the real world and our trials. Of course, in the trials, we closely follow people, but it's like using Coumadin. You wouldn't think of giving people Coumadin without an INR. You'd have a bleed. That would be malpractice. I think it's the same thing here.
With potassium. Well, thank you so much, Bert. We will certainly ask our listeners to look forward to this New England Journal paper in early April with the TopCat summary.
Thank you.
That concludes Disc 1 of ACCEL. For details about studies discussed, refer to the written summary that's included as a PDF on Disc 3. Disc 2 begins with the discussion of the role of sympathetic nervous system in hypertension, a historical